Welcome to this explainer on Captopril Renal Scans, also known as ACII renography. Finding the true functional driver of hypertension in a really complex clinical case, well, it can honestly feel a bit like hunting for a needle in a massive anatomical haystack. So let's dive into this source material together and uncover exactly how to use this incredible diagnostic tool to separate those mere structural incidentallomas from the actual physiological drivers of the disease. Okay, here is our roadmap for today. We'll start with the hypertension mystery, then compare anatomy versus function, and unmask the ischemia. From there, we'll move into patient protocols and workflows, look at tracers and scan interpretation, and wrap up with limitations and our final takeaways. Section 1. The hypertension mystery, or finding that needle in the haystack. Let's jump right into the true scale of the diagnostic challenge we're facing here. Think about the millions upon millions of patients managing hypertension globally. A staggering 90% of them have a completely unidentified etiology, what we call essential hypertension. Less than 10% actually have secondary hypertension. But here's the truly wild part. Out of all those unselected hypertensive patients, less than 1% actually have renal artery stenosis driving their disease. It's a tiny, tiny fraction, which means mass testing absolutely everyone totally off the table. Since we can't test everyone, we have to play medical detective. We're constantly hunting for clinical red flags that bump a patient up into that moderate risk category of 20 to 30%. We're talking about things like an abrupt onset in patients under 30 or maybe over 55, or severe hypertension that literally just laughs at a perfectly compliant 3-drug regimen. Also, you really want to keep your radar up for unexplained renal impairment right after starting an ACE inhibitor, or abdominal brutes, or even an incidentally discovered unilateral small kidney. Section 2. Anatomy versus function, the crucial distinction. Now, to effectively track down these specific cases, we have to grasp one really important philosophical distinction. Anatomy simply does not equal function. Renal artery stenosis, that's just an anatomic narrowing, usually from atherosclerosis. But just because a vessel is narrowed absolutely doesn't mean it's causing the high blood pressure. In fact, amazingly, over half of perfectly normotensive patients over 60 have atherosclerosis in their renal arteries. So if we just spot a narrowing and slap a stent in there without confirming it's the active driver, the intervention is probably going to fail. We have to test the kidney's actual function, not just look at its structure. Section 3. Unmasking the ischemia, the medical detective work. To really understand how we test this physiological function, we need to look under the hood at the engine of hypertension. When a kidney is starving for blood flow because of a blocked artery, it essentially panics. It kicks off the renin-angiotensin cascade. And as we know, this chain reaction ultimately pumps out angiotensin II, which is a highly potent vasoconstrictor. It tells the entire body to retain salt and water while clamping down hard on peripheral vessels. The ischemic kidney is literally jacking up the entire body's blood pressure just to force a little more blood through its own blocked pipe. So how do we actually catch it in the act? Well, in this compensatory state, angiotensin II artificially preserves the kidney's GFR by clamping down on the efferent arteriole, the exit pipe. It's basically hiding its distress. But during this scan, we administer an ACE inhibitor like Captopril to act as our truth serum. By blocking that angiotensin II, we pull away that compensatory back pressure. The efferent arteriole relaxes, and the GFR of the diseased kidney just completely plummets. We literally force it to fail on camera. Section 4. Patient protocol and workflows, setting up the test. The absolutely crucial point here is making sure our patient is perfectly prepped so we don't accidentally sabotage our own investigation. Before we even think about administering any tracers, we have to strictly enforce this prerequisite checklist. First up, calcium channel blockers are out. They cause vasodilation and trigger false negatives. Diuretics, those must be stopped for 5 to 7 days prior. Second, a strict 4-hour fast from solid foods just to prevent nausea. And finally, the ultimate arch nemesis of a good renal scan, dehydration. The patient must be extremely well hydrated to avoid massive false positive results. Once the patient is totally prepped, we move to the intervention timeline. You've got 2 main choices here. You can give oral captopril, usually 25 to 50 milligrams crushed up, 60 minutes before the scan. Or you can go with IV enalaprilat at 40 micrograms per kilogram over a 3-minute push, just 15 minutes before the scan. And during this waiting period, you absolutely must record the patient's sitting blood pressure every 15 minutes. Remember, we are deliberately dropping their compensatory mechanisms, so keeping a very close eye on their vitals is critical before hitting time zero and firing up the scan. Now, your clinic's workflow is going to dictate how we stage the test. You can opt for a sequential one-day protocol. That's where you do a baseline scan with a low dose of tracer, immediately followed by the post-Captopril scan with a much higher dose. Alternatively, there is the highly efficient 2-day conditional protocol. Here, you start directly with the post-Captopril scan on day 1. And if that Captopril scan is completely normal, congratulations, the test is over. The patient doesn't even need a baseline scan. They only come back for day 2 if that initial scan shows abnormalities that we actually need to compare. Section 5. Tracers and Scan Interpretation. Reading the clues. Let's see how all of this builds into our actual scan interpretation, where we learn to read the visual and mathematical clues left behind by the radio tracers. The behavior of your scan entirely depends on whether you choose MAG3 or DTPA. MAG3 is a tubular agent. Its initial uptake relies on tubular secretion, not GFR, so even after we give the captopril, the initial uptake often looks surprisingly reasonable. The true diagnostic signature for MAG3 is a delay in the later transit, showing increased cortical retention. DTPA, on the other hand, is a purely glomerular agent. Because our ACE inhibitor intervention directly crashes the GFR, a DTPA scan is going to show an immediate, definitive drop in initial uptake on the affected side. The scanner plots out a renogram time activity curve, which we visually grade from 0 to 3. A grade 0 is a beautifully normal curve with a nice, sharp early peak. Grade 1 shows just a mild delay, but by grade 2, we're seeing a severe delay where that peak takes over 11 minutes to arrive. And a grade 3, that's essentially just a flat line, indicating a total absence of parenchymal function. But, visual grading isn't enough on its own. We need strict quantitative thresholds for hard proof. For MAG3, we want to see the time to peak increase by at least 2 minutes or 40%, or the curve worsen by a full grade. For DTPA, since it's directly tied to GFR, we're looking for the differential renal function to shift by more than 5%, or the GFR itself to drop by 10% or more. Meeting these strict thresholds is what confirms the diagnosis in the reading room. Section 6. Limitations and Final Takeaways. The final verdict. We've gathered all our data, so let's move to our probability assessments and understand exactly where this powerful test might occasionally fall short. When writing up the final report, hitting those quantitative thresholds means a high probability, over 90%, for renovascular hypertension. If the baseline is abnormal but doesn't really change post-captopril, well, that's intermediate. But listen up, here is a massive red flag: bilateral symmetrical cortical retention. Do not automatically call this bilateral disease. It is very often just a false positive caused by severe patient dehydration or drug-induced hypotension during the test. Finally, a totally normal captopril scan yields a low probability of less than 10%. Now, as amazing as this test is, it certainly has its limitations. If a patient is already on long-term ACE inhibitors, the test's sensitivity drops pretty significantly because their system is already chronically altered. Furthermore, beware the indeterminate trap. In patients with severely poor overall renal function or advanced ischemic nephropathy, the kidneys are so badly damaged that they just won't mount a response either way. When that happens, you really have to pivot back to anatomic imaging modalities like MRA, duplex ultrasound, or traditional angiography, just to confirm the vascular status. Ultimately, ACI renography reinforces a deeply critical medical philosophy. Just because we have the amazing technology to see a narrowed artery doesn't mean we should automatically go in and stent it. The body is a highly dynamic system, so I'll leave you with this provocative thought to ponder. When managing complex refractory hypertension, are we falling into the trap of merely treating an anatomical shadow, or are we truly treating the underlying physiological function that's driving the disease? Knowing the difference could absolutely save your patient from an unnecessary surgery. Thanks for exploring this explainer with me today, and keep asking the right questions.